So now we're rounding the corner on the last major topic, extracardiac ECGs. And under this, our first subtopic is disorders of metabolism. The heart's action potential depends on the firing of ion channels. First, the voltage-gated sodium channel and the L-type calcium channel open, and this process leads to depolarization. And then potassium channels open, and they repolarize each cell. The point is that alterations in ion channel function actually make a big difference in the heart's electrical properties, and these properties can be seen on the ECG. In this section, we will talk about hyper and hypokalemia, and then we will talk about hypothermia and also some specific responses to drugs, such as digitalis and QT prolonging drugs. First up is hyperkalemia. You will often see hyperkalemia in patients with renal disease, patients taking potassium-sparing diuretics or ACE inhibitors. You'll see this in hypoaldosteronism or uncontrolled diabetes. For hyperkalemia, the hallmark ECG has peaked T waves on the ECG, as seen here. Look how symmetric and peaked and tall the T waves are in this ECG, especially in the precordial leads. The important thing is that in hyperkalemia, you diagnose this early, because worsening hyperkalemia can lead to ventricular tachycardias and can be fatal if untreated. So the ECG is a good way to screen for hyperkalemia in patients. On the opposite end of the spectrum is hypokalemia. Hypokalemia is commonly caused by potassium-wasting diuretics, diarrhea, primary aldosteronism, and alcohol abuse. The ECG may show a low T-wave amplitude, ST segment depression, T-wave inversion, and PR interval prolongation. The next is hypothermia, something that is common in the northern climates in the northern hemisphere and also is common in patients who are unconscious from drug usage. The hallmark of hypothermia on the ECG is the Osborn wave, a sharp J-point deflection on the ECG that is often seen in the precordial leads. It is often accompanied by ST segment depression or T-wave inversions in bradycardias, as you can see here. Our next ECG is a classic one that you will see with many patients who have a history of atrial fibrillation or heart failure. And this history is commonly seen on question stems on major board exams. In both atrial fibrillation and heart failure patients, they may be on a drug called digoxin, which is an inhibitor of the sodium-potassium ATPase in the heart. And the net effect of this partial blockade in the AV node is blockade of the AV node and increase in calcium-induced contractility in the heart. Unfortunately, with digoxin, there's a fine line between drug efficacy and toxicity. And so sometimes patients will have AV nodal block and potentially altered ECG findings. The ECG here is a classic one for digoxin toxicity. You can see that there is scooping of the ST segment, and there's a sagging of this ST segment, especially in leads 1, 2, and 3, that kind of looks like a hammock. So you can see these sagging, scooping ST segments that have a hammock-like appearance in digitalis toxicity. Here's an example that you've seen earlier, but I just wanted to briefly remind you that there are many drugs that can cause long QT intervals on the ECG, including sotalol, which is an antiarrhythmic drug. So look in lead 2 below. You can see that the QT interval is about half of the R to R interval. And there are a lot of drugs that can cause QT prolongation. Sotalol is our example here, but also antihistamines, antibiotics like quinolone and erythromycin, antidepressants like amitriptyline, and also methadone, for example. So on tests, you may be asked about patients who have a predisposition to long QT, and then you will be quizzed about not adding drugs that might prolong the QT interval and cause serious arrhythmias like torsades de pointes.